So we're going to talk about flat urothelial lesions with atypia, which, as I've talked to a couple of you, I think this is one of the more difficult things in all of surgical pathology that you could possibly do. So what I'll just tell you is my approach to doing it, and I hope you find it helpful. So the modern classification, I'm not going to go through the whole history, but I'll have a list, but it basically started in 1998. And we'll get to that. But I was fortunate to be able to work with the group that that did the one from 2016 in the WHO. Anyway, I'll go into the detail about the history. But as you all know, that invasive urothelial carcinoma can arise from two pathways. It can either arise from a papillary tumor or it can arise from a flat tumor. And historically, it was kind of a leap to recognize that tumors could arise from something flat that the urologist could not see through the scope. So this is kind of a quick history. Basically, there was an industrial exposure of para-aminophenol around the shipping yards. And as you can see with the numbers down here, a lot of these men developed urothelial carcinoma in situ. And that was really the first time there was a large population that could be studied. And at least to my knowledge, that was the first time that it was documented histologically that, these flat lesions could be fully malignant and could progress to invasion without going through a papillary step. Now the classification, the problem was until 1996, was that basically every hospital had their own classification system. So you couldn't compare between hospitals. And my mentor, Mahul Amin, came up with the classification in 96, which basically became the 1998, which was then the 2004, then the 2016, and it's still the 2022. So that's what I'll be kind of teaching you today. So basically, if you have a flat lesion that's atypical, your choices are reactive, which is totally benign. It's atypia, I'm not sure. Urothelial dysplasia, which is very poorly reproducible, and we'll talk about how I handle that, and urothelial carcinoma in situ. So the main goal of this talk is the two things you need to learn is what's your low threshold for carcinoma in situ, like what's the lowest atypia that you can have to call carcinoma in situ, what's the highest amount of atypia that you can have to just call definitely benign reactive. And then you don't need to worry so much about the things in between. You're wasting your time because they're unresolvable, and I'll tell you the easy way to deal with that. So normal urothelium is weird looking. There's a lot of variation, and a lot of benign urothelium gets diagnosed as dysplasia or different things. Oops. So basically, and you'll see this picture again. At the base, the cells are streaming upward in a linear fashion from the basement membrane perpendicular. The nuclei are often elongated. Okay, they're not rounded, they're elongated. And they often have little grooves. It may be hard to see them in maybe one or two, but this is pretty normal. Now obviously, if you get the section cut too thick, they look a little darker, so there's going to be a lot of variation from stains and thickness. But this is about normal. On the other hand, carcinoma in situ is markedly atypical. So the cells start to round up. The nuclear chromatin gets dark. The nuclear membranes are very irregular. Now, of course, this one I think is an easy one, right? This is floridly malignant. We're going to look at all the variations in between because some of these are really hard. But the main thing that to diagnose these is large irregular hyperchromatic nuclei. That is what you're looking for. And really almost nothing else matters, okay? And this is one of the keys when they started the classification in 1998. These were the things that needed to be changed because this is what other hospitals were doing. And as a matter of fact, you could read in textbooks that urothelial carcinoma in situ was classified the exact same as the uterine cervix, where if the atypical cells were at the bottom, that was low, and then if they went up to the mid, that was moderate, and if they went to the high, that was CIS. That is completely false. Okay? If you have any high-grade urothelial cells, no matter where they are, that's CIS. And I will show you why, because there are examples where the high-grade cells percolate through the normal. And those cells can progress to invasion. So if you didn't call it CIS, you'd be underdiagnosing the patient. But we'll get to that. The other thing is the umbrella cell on top may be intact. So sometimes you hear people say, well, the umbrella cell layer is intact. That can't be CIS. That's false. And then finally, sometimes the cells have quite a bit of cytoplasm. So it's actually kind of rare to have a high nuclear to cytoplasmic ratio in CIS. And I'll show you some examples of that. So again, on the left, this is carcinoma in situ, and on the right's that picture of normal. Remember the orientation. This is what the WHO calls disorder, okay? So this is order, where the cells stream perpendicular to the basement membrane. So this is the lumen, and the lamina propria is down here. On the left, if I covered up this part and this part, I don't think you'd be able to tell what's lateral, what's luminal, they're just completely disorganized. The other thing is they're markedly enlarged, they're hyperchromatic, and there's a lot of variation in nuclear size and shape. And even, look at the nuclear membranes have notches in them. Again, this is a fairly florid example. I think this should be an easy carcinoma in situ. So this is the first step to learn. The first step is to learn how to recognize this. And then you have to start learning what's less atypia and less atypia and less atypia that's still definitive carcinoma in situ. Okay, that's my goal today. So what really helps is if you can compare the CIS to normal. So obviously this is a von Brunn's nest, and this is a von Brunn's nest that's filled with CIS. Look how much larger these nuclei are. The nuclear chromatin's a lot more irregular. So that's a great example of the nuclear size. Okay, so a couple more side-by-sides. The one on the right, to my eye, is reactive. Again, there is some variation. Normal urothelium is always strange looking. But for the most part, some are still elongated. The chromatin is relatively fine. Again, it depends on how thick the section is. Over here, this is marked nuclear hyperchromasia. Like very coarse, they're rounded. It's kind of lost the orientation again. So again, to me, this is florid carcinoma in situ. This is the first step. You got to learn how to recognize this, because everybody should call this carcinoma in situ. There's no other answer. I often say, and I'll say this again, in most reports that you make, there's several right answers, okay? There's not just one, there's several, but there's hundreds of wrong answers. So just don't make one of the wrong ones. Pick one of the right ones. But this one has no other answer but carcinoma in situ, okay? Now, I've talked about nuclear size, and this is a study that I wish I had done, but I didn't do it. The Johns Hopkins group did this before we did it. But so I would argue, see these large cells, and I'm going to show a higher power. This is carcinoma in situ up top, and this is normal at the bottom. Okay? So if you can use the stromal lymphocytes as a guide to the size, and it works really well. Now, you can't just use this alone, but it's a nice little guide. So if I take a lymphocyte, and I say that's the size of the lymphocyte nucleus, and then I take a normal cell, generally you can put 2 or 3. If they're reactive, maybe 3.5, maybe 4, maybe. This is a carcinoma in situ. What do I get in there? 1, 2, 3, 4, 5, 6. You could probably put a 7th one in there. So if you're like at 6 or 7 or 8, you're probably CIS. Now you have to look at all the other features, but that's at least a first guide. So sometimes when I'm looking at cases with the residents, and they're worried about the urothelium being dysplastic or whatever name they're worried about, I tell them the nuclei are way too small. And so that's really the first guide. So if I saw this, I really wouldn't look at it too much, because I can tell how small the nuclei are. Okay, so now let's just look at a few more. Again, a lot of the nuclei are rounded up, but there's, again, a lot of variation in size and shape. There's a little bit of clumpy chromatin. This one is not as hyperchromatic as some of the other ones I've shown you. This one, that you can see the cytoplasm has a lot of pink cytoplasm, right? So that doesn't matter. Again, what I should have done is said, look at this lymphocyte. You probably put 8 in there. In this case, if this is a lymphocyte, 1, 2, 3, 4, 5, 6, 7, 8. So this is markedly enlarged. You can't go on mitotic figures, but there is a mitotic figure here. And again, these are markedly enlarged with a lot of variation. So is everybody okay with carcinoma in situ for these two? No? What bothers you? What's that?
Your previous slide says does not always have high NC ratio.
Uh-huh.
So it's not obligatory to have big nuclei?
No. The issue is they will always have big nuclei, but sometimes they still have a lot of cytoplasm. So it's not that the nucleus is small. It's that they still have pink cytoplasm.
Nuclei are always big.
They're always big, yeah. Now I'll show you one variant where they're not quite so big, but they're still big. But that's the harder cases, okay? What I want you all to be able to recognize this very confidently, that both of these are CIS. There's some, well, we'll get to, there's some versions that are difficult, and that's okay. If you wanted to call them atypical suspicious, that's fine. But I don't want anyone in this room calling these atypical suspicious, because that is carcinoma in situ, and these patients have a very high risk of developing invasive bladder cancer. Okay? Now we talked about the thickness can vary, and this is just an example of that. You can see that this is almost completely denuded. This is very flat. This kind of looks normal, and this looks thick. So it doesn't matter. It's the cells that are present. That's all that matters. And even this one, that has an intact basal cell layer that's benign. So, and that doesn't matter, okay? So a long time ago, probably one of the first papers that I ever did, we studied all the different patterns of carcinoma in situ. And these names, don't learn the names. It's just to demonstrate that urothelial carcinoma in situ is heterogeneous, okay, within terms to morphology and growth patterns. So we're going to look at them. So some are markedly pleomorphic, and these should be the easiest ones to recognize. Some of them are less pleomorphic, so all the cells kind of look the same. And again, here's one that there's a lot of pink cytoplasm, but if you take maybe that's a lymphocyte, you can at least get 6 in here. These are very enlarged. They're very hyperchromatic. Okay? This is a nice example because these are starting to round up, but they don't look near as pleomorphic as some of the other cases I've shown you. Let's see. If this is a stromal lymphocyte, again, you can put probably 5 or 6 in here, 6 in here. Now, here's some examples that don't have cytoplasm. This is a terrible name. Don't use this. This has nothing to do with neuroendocrine differentiation. But unfortunately, this is what they were originally called when this was described back in the 80s. But it just means this is probably the best example here. They just have very little cytoplasm. So sometimes they're actually harder to recognize when they don't have cytoplasm because the cells don't look quite as big. But you can see how big these are. Okay. This is very common. This has been called clinging or denuding. This is my favorite picture. I took this more than 20 years ago and I still use it. But these are benign basal cells. Okay, so you can have benign denudation and you can have CIS that's denuding. Okay, that's why I like the picture because you can see both. We see this every day. We see benign denudation and we see CIS that's denuding. And sometimes you'll actually see it's completely broken off and floating. And I'll have a slide on this, so I'm going to repeat myself, but I'm going to say it since I'm here. If you get a biopsy that looks like this, we sign these out as this way. So usually every urothelial biopsy I start off with benign urothelial mucosa with. And the reason is, if the urologist wants to turn their brain off after they read those 3 words, that's fine. Because if you start with von Brunn's nests or cystitis glandularis, you're going to get someone in trouble. So always start with benign urothelial mucosa, and then you can say whatever you want, okay? But on these, I just say denuded urothelial mucosa. And my urologists know what that means, but if you wanted to put a comment, the comment would be that you need to correlate with the cytology. And the reason is these are floating around in the urine and they're not in your biopsy. And I have another slide that goes into more detail about that. Okay. Now this is a great example about why you don't require full thickness. This is pagetoid urothelial carcinoma in situ. Just as every other example I've shown you, these can invade. But look, this has normal going all the way to the top. So you may just have 1 or 2 cells mixed in, and that's still urothelial carcinoma in situ. Okay, and again, they have a big prominent cytoplasm that's very common for them, so they kind of stick out on low power, so you'll see them. But that's a great example of pagetoid CIS. Okay, is it okay if I know this is one of my rules, but I've said carcinoma in situ enough now, can I switch to CIS? Can everybody follow me if I say CIS for carcinoma in situ? Yes? No. Don't do that. Yeah, don't do that. Just, your diagnosis should be urothelial carcinoma in situ. So all of these names, it's just for recognition, so pathologists are aware that this can happen. So this is a nice example of undermining growth, where it actually grows underneath and it lifts up. So this is florid reactive. So it's another nice example. You know, the cells are getting a little funny, but they still have fine chromatin. We'll get to this, but the cells grow underneath. Rarely, I don't even have a great picture of it, but maybe 2 or 3 times I've seen the carcinoma in situ just grow over the top. But that doesn't happen very often. Okay.
Can you show the previous slide?
Sure.
I want to ask, is it the intact umbrella cells on the top?
There probably is. They're hard to see. So umbrella cells are easier to recognize when they're big and atypical, and they're vacuolated. But there probably is, but it's hard to see. I'll show you some cases where the umbrella cells are really prominent. Mm-hmm. Okay. This is the hardest one to recognize. And if you struggle with this, that's okay. I think at least just recognize to call these at least atypical suspicious. So these cells actually are enlarged. They're just not quite as enlarged as most cases. So if you take a lymphocyte, I probably can get 5 in here maybe. Some of them maybe 6. But they see how the nucleus is eccentric, and they have this pink cytoplasm, so obviously plasmacytoid. Here it is on higher power. And these can be more subtle, again, because the nuclei are more monomorphic, and the chromatin's not as atypical. Here's another example. And this is when they're difficult, okay? I admit. But when they're clinging, they can have a lot of overlap with the normal basal cells. And, it's hard for us, and we show it to our whole group, even though we've seen a lot of these. So you should just be aware that these little plasmacytoid cells, it's a form of CIS. And if you have any, cases like this that you find difficult, you can always just call them atypical. That's okay. And on I don't do cytology, but one of my colleagues, when we described this, she wanted to see what the cytology correlate was. So she went back and looked at the urine for all these. And you do see the plasmacytoid cells, but apparently, and again, I don't know this because I can't quote all the rules and criteria, but by the Paris criteria, they don't reach the threshold for CIS. So in cytology, these would almost always be atypical. Do you have a question?
In which cases do you do cytology? In every cases?
That's up to the urologist. So the question was, when do we do cytology? And that's up to the urologist. But I suspect that they do in almost every case. If they're going to do a biopsy, they do the cytology as well. Okay, and then one of the last ones is, this is weird, but rarely these actually start to have glandular transition. So this is CIS with glandular differentiation. This is probably the only one that I actually would list in the diagnosis. But I would start off with urothelial carcinoma in situ, right? Because then they can turn their brains off. And then you go with glandular differentiation. But so you should just, don't get worked up that this is something different. And most of them you'll have areas of urothelial atypia, and then or flat classic CIS, and then it'll just transition to these areas of glandular differentiation. And we're not going to talk about it today, but you can see this in non-invasive papillary tumors too. It's often called viloglandular differentiation. Okay, here's the denuded slide. So a couple groups have looked at this, and if the urologists do the biopsy with any kind of heat, then most denuded biopsies are just artifact. They induced it by the hot loop. If it's a cold cut biopsy and it's completely denuded, then those have a high risk of carcinoma in situ. Okay, so we don't necessarily know exactly how they do it. So if we see denuded, we just say, given that the surface urothelium is denuded, correlation with urine cytology is highly recommended. Okay, and that's basically how we handle those. These I would regard as, and again, I recognize if you haven't been looking at a lot of these, this is hard, but these I would regard as not CIS. I think these are just basal cells. They're not basal cells, but the basal layer of the urothelial cells. And again, the reason is when these denude, they're floating in the urine. So the urine cytology in a CIS is often floridly positive. Okay, any questions about CIS before we go to the other end of the spectrum? Which type? Which? Not that we know of, the glandular CIS. The reason that I list it is if somebody else gets a biopsy and they see something glandular, they need to realize that it's urothelial and not an adenocarcinoma. Because by the way we define these is just the rules. If you have any urothelial component, it's urothelial. So to be adenocarcinoma, it's got to be 100% pure adenocarcinoma. You can't have a urothelial component. But in terms of outcome, I don't think those have a higher rate of becoming invasion with glandular differentiation, but they're so rare we don't really know. Does that make sense? Okay. All right, so we're going to do reactive atypia next, because remember, my goals here was to make everybody comfortable with CIS, and now I want everyone to get comfortable with reactive, and then everything in between, we're not going to worry about. Okay? So to me, this is classic florid reactive. It's very common to have neutrophils mixed into the urothelium, which you can see. So the nuclei will be enlarged, but the chromatin is often really fine, okay, really even and fine, and you'll often see one or two prominent nucleoli. So like this nucleus, that's about as classic benign reactive atypia as you can see. So I would sign this out as benign urothelial mucosa with reactive atypia. Okay? Because then you don't, if you use the word atypia, you don't want to put that first, because then the urologist, that's all they can think about, is that it's atypical. So if you start with benign, you never have to worry about that. I do that on all my reporting, by the way, even if it's ridiculous. Like if I have a leiomyoma, I know it's stupid, but I say benign leiomyoma, because people are becoming less nuanced and knowledgeable about pathology. Oh man, I'm surprised every day, but anyway, that's a whole other story. Okay, so I have this one on the left because I wanted to make the point. I don't know how many textbooks have written that carcinoma in situ has mitoses in the upper levels and reactive is at the base. I don't know where they got that. This is florid reactive, and look at all these mitotic figures up here. Okay, so again, they still are sort of streaming upwards. The chromatin's relatively fine. They have multiple nucleoli. So to me, this is a great example of like really florid reactive atypia. This is another example. These are the ones that are harder because they look darker. but the chromatin's still relatively fine. In some areas, you can still see the grooves. And if you compared them to a lymphocyte nucleus, let's take that one. Maybe you get 3. These cells are actually quite small. Here's another one. You can see the neutrophils mixed in. This is my first slide. I'm going to have a whole little section on immunohistochemistry. This is Ki67. That's reactive. What do you think I'm going to say? Don't do this. Do not do Ki67 in flat urothelium. It does not distinguish benign from malignant. Okay? Okay, don't look at the images. Read the top. Okay? Because if you look at the images, you're going to be freaked out. Okay. This was a kid who was in a car wreck and had a bladder injury and had a long-term indwelling catheter. And for a reason that defies any logic, when they pulled the catheter out to fix the thing, they did a biopsy. Okay? So my point is that reactive atypia can be quite florid. Like, I know this is reactive because of the clinical scenario. If this were an adult, I probably would have signed it out as atypical, uncertain significance because of all see, all these are neutrophils. So I would have backed off, but look at this mitotic figure. This is another thing in pathology that I don't get. Atypical mitotic figures. I mean, this is florid reactive. Is that typical? I don't think so. But anyway, this is just kind of the crazy spectrum that you can see in reactive. But again, I was guided by the clinical. I knew that this child didn't have carcinoma in situ. That doesn't happen. And he had major trauma to the bladder. Well, we had to go chase this down. Yeah. Because we saw the patient's age. Like, you just wouldn't diagnose urothelial carcinoma in situ in a 5-year-old.
This picture is in an adult. It's atypical.
No, this picture's from the kid. This is from this patient.
No,
If it was an adult. Yeah, I would, because of all the acute inflammation, I would probably call this urothelial atypia of uncertain significance. Yeah. But it's just to make the point, I know this is benign. So I'm just showing you what can happen that's still benign. And this is one from an adult, and this is what I did, this has a lot of inflammation, but it also has a lot of atypia. But with all of these neutrophils, I would back off and just call this atypia of uncertain significance. Okay. So any questions about reactive cytology or reactive before we do the middle ground? Yes?
You said that the mitotic figures can be in every level.
Yeah.
Does that apply even in the papillary lesions or only in flat?
So you're talking about grading of papillary lesions?
Yeah, that we are thinking about high grade, low grade.
Yeah, well,
Do we use mitotic figures or just forget about it?
so the question is, do you utilize mitotic figures for grading? Officially, the WHO, it's just on the cytology, it's not on the mitotic figures. But admittedly, if we're like borderline, low grade, high grade, and we see a lot of mitotic figures, we'll probably call it high grade. But that's not written down anywhere, that's just,
Okay, but for example, if general lesion looks more like low grade, but you have mitotic figures in an apical part of it.
yeah.
That's not something that should like push it.
So the question is, if you have a low grade and you have mitosis high, would you automatically call it high? No, if the cytology is really low grade, I would let it go as low grade.
Okay.
But you have to make sure that your threshold, the threshold for low grade and high grade was reset in 1998. And some people are still being taught what we were doing in 1973. So the threshold for high grade was moved way down. Uh-huh.
One of them is if there's a threshold for the number of atypical cells. So if they are big, the nuclei, and it's very typical, but it's like only 1 or 2 of them.
Yeah. So the question is, how many cells do you have to call carcinoma in situ? There's an old commercial in the United States about Tootsie Roll Tootsie Pops. Do y'all know this one? Do y'all know what a Tootsie Roll Tootsie Pop is? So it's a lollipop, but there's candy in the center. And so there was an owl who would lick the lollipop, and they would say, how many licks does it take to get to the center of a Tootsie Roll Tootsie Pop? Anyway, the answer is however many cells you're comfortable with. If you say these are malignant no matter what, then if you just have a couple, you could probably still call it. But if you're uncomfortable, then you can just call it atypia of uncertain significance. But there's no well-defined number. It's just because if they were large and pleomorphic and hyperchromatic, it doesn't take that many. If they're monomorphic, you'd probably be more hesitant, and that's okay. It's one of those. There's more than one right answer for those cases, as long as you don't call it benign.
My other question is, if I see atypia, but I see a lot of neutrophils, does that automatically make me think that it lowers my...
Yeah. So the question is, are you more hesitant to diagnose carcinoma in situ if you have a lot of neutrophils? Yes. This is a great case. Like, I don't know what this is. I suspect this is very fluid reactive atypia, and I bet if we looked it up, this patient had an indwelling catheter, and they, again, did one of those things that was really not a really bad idea, which is to pull the catheter and do a biopsy right after you pull the catheter, because this is what you're going to see. We'll talk about that. You just have to be careful with that kind of stuff. But, but here's the question. Let's say you do CK20 and these cells are positive. Yeah, and you have all these neutrophils. And you have these like nucleoli that look reactive. What are you going to call it? P53 is wild type. CK20 is diffuse. What are you going to call it? Okay, I don't like that, but I'll tell you what. So the reason we went through this exercise is, if you're going to order the immunostain, you got to know what you're going to call it when it's positive. And if I ordered CK20, it's not going to change what I say, because I'm not going to call this. So I know before I order the stain, I'm not going to call it. So therefore, I don't want to know. Yeah.
Does it matter if the patient has another papillary tumor, and does it matter how to write if he has a papillary urothelial carcinoma, and can we write this CIS more?
Okay, so the way I'm interpreting this question is, what if there's a papillary lesion, does it affect how you do the flat lesion? In general, if they're in the same container and the papillary lesion is high grade, it's probably just the base of the high grade. If you have a high grade papillary in one container and then a separate biopsy is flat, then you can call it carcinoma in situ. But I'm hesitant if it's in the same container, because it may just be the base of the, but as long as you say high grade in one, it doesn't really matter. As long as you give them a high grade that's non-invasive, it's kind of the same thing. People will argue, but if they have CIS, they're higher risk, and yeah, it's not going to change the way they manage. That's a lot of hand waving, as we say. Yes? Uh-huh. Absolutely. Yes. So the question was, does CIS colonize von Brunn's nest? And so you can have like a normal surface, and the von Brunn's nest can have CIS. So one of the first pictures I showed was actually CIS in a von Brunn's nest. Yep. And it's important that you not call those invasive. It's still CIS. All right, we're doing great. All right, so let's talk about some benign mimics of CIS. So I promised I would show you some good umbrella cells. So umbrella cells actually look quite atypical. They can be multilobated. They're often vacuolated. They can often have this dense pink cytoplasm. So this is just a classic benign umbrella cell layer. So this is normal urothelium. Again, see how much variation there is? Like, these are a little bit rounded. They're not as elongated as these. You're always going to see this kind of variation. But if this is a lymphocyte, look how small these are. 1, 2, maybe 3. That's it. But these are nice umbrella cells. Now, if you cut these tangentially, it's going to look like this. That looks quite atypical, right? So you have to realize, see the vacuolization? That these are they basically cut these umbrella cells, so you're seeing a sheet of them en face. Does that make sense? Do y'all know what en face is? Where you're basically, the knife is cutting them in plane into the screen. So you're just seeing a sheet of them. Okay, this is radiation. So post-radiation, it makes all the cells look like umbrella cells. So you get more vacuolization, you get a lot of multilobation. You can get fibrin deposition and accumulation. Again, see how this is multilobated? So if I ever see something like this, particularly with fibrin, you automatically go look and see if the patient's had radiation. Okay, now this is going to take us into something a little different, but I wanted to get this into the this week at some point. So we're going to talk about radiation hyperplasia. So it's a little bit off topic, but that's okay. So if you see this in a biopsy, this patient had radiation. I don't care what anyone tells you. This is vascular injury from radiation. You've got the fibrin, you've got spilled red blood cells. This is classic radiation change. Now, again, on low power, look at the top. You've got blood lakes, you've got fibrin. Here's organizing fibrin. But look at the base. The urothelium is actually underneath all that, and it's these irregular clusters and nests. So this is actually radiation-induced hyperplasia. And the way you don't want to look at these, you want to recognize this. And if you recognize this, then you know this is hyperplasia. Okay? And very characteristically, these nests start to wrap around areas of organizing fibrin. That's very characteristic. And if you see this, we see so many of these, and they all look the same, and you can be very confident. See how it's wrapping around the fibrin? If you see that, you can be very confident this is benign hyperplasia. And once you see 2 or 3 of them, you'll become comfortable with it. And again, obviously, the background looks like radiation. This looks like one of those fetal vascular things. Look at this. Epithelium is wrapping around this organizing fibrin. Classic hyperplasia. Okay. Again, if you just focus on this and you ignore everything else, you're going to call this carcinoma, right? Every time. Okay, so that's radiation-induced hyperplasia. How many of you have patients who are getting mitomycin instilled in their bladder? Anybody? Okay, that's probably good. So mitomycin induces some really crazy atypia. So this is, to me, kind of classic, where the cells, see how the cytoplasm gets stretched out? It reminds me of the classic reactive cells in cytology, where the ends get stretched out, and you have this pink cytoplasm, and there's inflammatory cells mixed in. But when the cells are going sideways, not up and down, but they're going sideways like this, that's almost always florid reactive changes, and this one's due to mitomycin. Now the next slide is going to be scary, okay? But if you're not seeing mitomycin, you don't have to worry about it. So the mitomycin changes can be down in the von Brunn's nests, and then the surface starts to become normal, and you get these pockets of atypia. And this is very difficult. That's okay. I just want you to be aware this happens. Don't worry about it too much. Even people who see a lot of these have problems with this. But mitomycin really creates a lot of atypia. That's the only point I want to make. So here's another example. It almost looks squamoid. It looks very pink. And that's what tips us off that it's mitomycin therapy. It's very, very pink. And it's, the other thing is it's abrupt transition to what looks like normal. Yes?
Is there any papillary lesion in this case?
No.
So this is the flat area.
This is all flat. Yeah, there's no papillary lesion. Yes?
Is it possible to differentiate these and post-radiation changes in CIs if patient has both?
If they have radiation and mitomycin?
CIs at the same time.
I'm not sure if I've ever seen that. That would be like cruel and unusual punishment, wouldn't it? To give someone mitomycin and radiation. That's called torture.
Call it reactive, not CIs, in all these cases.
These, yeah. Or, if you wanted to call it atypia of uncertain significance and say that you can't exclude therapy effect, that's fine. That's fine. Again, for these lesions, I think there's more than one right answer. I think that'd be okay. But these are atypical. These cases, this is the hardest slide I'm going to show you. But if you're not seeing mitomycin, you don't have to worry about it. We don't really see polyoma virus much on biopsy. It's more of a cytology thing. I just included it here but if you're doing urine cytology, you have to be able to recognize polyoma virus and distinguish that from CIS. But I don't do cytology, so I don't have a lot to say about that. So this is flat nephrogenic adenoma. So we could go through all the dozens of patterns of nephrogenic adenoma, but the only one that's really relevant to this talk is the flat. So you get this benign cuboidal layer of epithelium. It's a single layer, and if these were on papillae, that's papillary nephrogenic adenoma. So this is very characteristic. They can kind of have these snouts. If you see the cysts or the small tubules underneath, it's easier because this is more classic nephrogenic adenoma. If you want to do it, you can do a Paxate, and they will be positive if that makes you more comfortable. But this is pretty characteristic of flat nephrogenic adenoma, which is benign. Okay, here we get to your immunophenotyping. So in general, if you were only going to do 2 stains for flat lesions, to me, these are the 2 best. And I realize that probably not many people have CD44 because there's not a lot of other uses for it. We have it because we get so many of these, but frankly, I don't order it that often. What you have to realize is if you're going to do CK20, it often stains the full thickness of CIS, but the sensitivity is only about 85%. So 15% of CIS will be CK20 negative. So you've got to be okay with that. Right? You can't just use this exclusively. And CD44 gives you the exact opposite. It's like a mirror image. So this will stain all the reactive cells. So let's take a look at this. Oh, you can diagnose CIS on H&E, okay? You don't have to do this. And we rarely do it. Okay, so this is a great case. So this is undermining CIS. Here's the surface that's being lifted off. It's even got an umbrella cell layer. So to me, this is unequivocal CIS. So I would have never stained this, okay? But it has stains. So the CK20 stains all the atypical cells. These are the benign reactive cells up here, which are negative. And then CK20 also stains the umbrella cell layer. So this kind of shows you what it does. CD44 does the opposite. It's negative in the lesional cells, and it stains really strongly the underlying reactive cells. And you can see the umbrella cell here, it's negative. So it's an exact mirror image. And that's why, if you're going to do it, I like these 2 together. But again, I would have called this CIS, and I would have already been signing out the next case. Okay, so this is a weird-looking reactive atypia. So the chromatin's fine, but there's these big nucleoli. I don't remember what the clinical scenario was here, but to me, this chromatin is very reactive. This is not the clumpy, hyperchromatic chromatin of a CIS. And again, here's the stain. The CD44 is strong and diffuse, and the CK20 is only on top. Actually, I think this is probably the better use of the stains. How many people would be uncomfortable calling that just benign? It's okay, if you are. But if you wanted to use them to help you feel more comfortable calling something benign, that's fine. We don't do this, but some people do these combined dual chromogen. So this is all 3 stains on one slide. It's pretty, but it's a little bit of overkill in my opinion. So CK20 is brown. So this is a pagetoid CIS, right? So there's cytoplasmic staining in the CIS cells. CD44 is red, so the benign reactive's all red. And then they did P53, which I'll get to in a minute. But this one had diffuse nuclear p53 staining, so it had all three. Okay, so the key is that H&E is the gold standard, not the immunophenotype, because there are aberrant immunophenotypes, okay? So you will find cases of CIS that stain with CD44, okay? You will see CIS that's CK20 negative. You'll see every combination you can. And all jokes aside with your earlier question, I don't like the immunos for flat lesions that there's no way I would call CIS. And I'm going to tell you why. So if I don't think it's CIS, if the question is reactive or maybe dysplasia, the stains aren't going to help you. Okay? Okay, with regard to these two other stains, P53, it works. You know, P53 abnormalities is one of the underlying molecular mechanisms of urothelial carcinoma. And it's just like in the GYN tract. There are two patterns. You can have the diffuse nuclear or you can have loss. So null and overexpression both are positive. But I find these almost impossible to interpret in the bladder because you've got so many reactive cells mixed in, and distinguishing that from wild type, at least to me, I have a hard time doing it. Ki67 you should just never do in these. You should just never do them. If you want to do P53, you just have to be very careful in your interpretation. So this is a CIS with P53, and you can see all these are the reactive cells. And you know, is that a CIS cell or is that reactive? Is that a CIS cell? Probably. So this is probably overexpressed, but you know, do you see what I'm saying? It's hard to tell whether this is wild type or not, because it's hard to tell which cells are reactive or not on these immunostains. This is a null phenotype, and these are positive in the residual benign basal layer cells. So this is actually, the null phenotype is probably easier to read. And this is normal, so this is wild type, right? You have some that are strongly positive and some that aren't. Again, it's very highly dependent on your titer from lab to lab, and that's why I refuse to do it because I don't feel comfortable interpreting them. But I'll leave it up to you if you want to do it. We wanted to try to end this, so we did this paper just to prove to people to please stop doing this. And if you want to see the overlap, 8% of the CIS cases had less than 10% Ki67. And you could say, oh, but it's only 8%. But yeah, what if your case is one of those 8%? It's close to 10%. That means like 10% of the time you could have a low Ki67 in a CIS, and that means you would undercall it to at least 10% of the time. And with reactive, we had 20% that had more than 50% Ki67. So theoretically, you could overcall 20% of the benign reactive as CIS. So anyway, long story short, we never do it. Here's that same case I showed you. What's that? Yeah, but my point is that this was the Ki67 rate in this case.
But when we do I prefer to do the immunohistochemistry when there is suspicious. I'm not sure. It seems like CIS, but I'm not sure. So I do the immunohistochemistry, and you ruined this. You ruined this.
I wouldn't do that.
Because I got two cases. We said 2 months ago that it was a small area because biopsy was not great. There's two small area. I'm suspicious for CIS. I don't know what to do. I find one mitosis, and there's some cells, like here's 4 or 5 big cells. I did the immunohistochemistry, so it's not supported me. So I'm afraid to write CIS, and I write that there's some atypical. No, I didn't write atypical. Sorry, I wrote that immunohistochemistry not supported my suspicious to CIS. Recommended for follow-up.
Yeah. So in that situation, look, if you think something is CIS and you don't see enough and you want to do the stains to make yourself more comfortable so you sleep better that night, That's fine. I understand. It's how many of these you're seeing, but just realize that there's going to be cases where it's going to give you the opposite information.
Yeah, so
You just have to know that. That's all I'm saying.
only based on one
You got to do what you're comfortable with.
So if I'm sure it's CIS, I can support it for immunohistochemistry. If I'm not sure, there is no way to do
But
immunohistochemistry.
yeah, but if we drew out the logic of this, if we forgot pathology and we're just going to teach logic today, and we wrote up a logic equation, everybody would think we were crazy, right? Because that's illogical. But we just have to, because a lot of these immunostains, we're doing it for our anxiety, right? I mean, that's true, right? That's what we're doing. That's okay. You just need to be honest with yourself about what you're doing. So again, this is a florid radiation-induced atypia, and again, look at the key 67. Okay, so this is the biggest one. I've been talking about doing this study forever, and Dr. Williamson, who's moved to the Cleveland Clinic recently, who's now my colleague, he did this. So what they did is they took flat lesions, they did the stains, and then they wanted to see, okay, who progresses to definitively CIS, unequivocal, or invasion. And what do you think was the best predictor? Having a prior history of cancer was the best predictor. Okay? And so the immunohistochemistry did not predict outcome in any of the atypias. That is the best thing that I can say against just, my point is, if you want to use these, that's fine. We do on rare occasion, but you can't let the immuno run your diagnosis by itself. Okay? That's going to get you in trouble. That's my main point, is don't just close your eyes and go by the immunostains. Okay, that's always a bad idea. Okay, now I promised I would tell you the in-betweeners, that we're not going to worry about that. So in the WHO, classically, they've always had benign reactive. So again, just to reiterate, the most important thing, this threshold for reactive, I want you to get comfortable with that, and this threshold for CIS, get comfortable with that. Anything in here, you're wasting your time and your energy. So there was atypia of uncertain significance and dysplasia. The way I do it is I call all these atypia of uncertain significance. And the reason is dysplasia, nobody knows what the natural history is. The urologists don't know what it is. It's completely not reproducible. I could take cases, if I could pick 20 cases and send them around to whoever you wanted me to send them to in the world, who you thought was a good bladder pathologist, and the diagnoses would be all over the place. I'm not okay with that. If we can't have that, if we have that much variation amongst experts, then we should just lump them all into the we don't know category. So that's what we do. Yes?
My question is, we can use the dysplasia in these cases if the clinicians are used to that.
I don't use the word because I don't think it's reproducible. So the way I sign them out is urothelial atypia of uncertain significance, see comment. And I say that this degree of atypia does not reach the threshold for CIS, but I can't entirely exclude the possibility of early, flat, low-grade neoplasia, i.e. dysplasia. That's what I do. So I'm going to just show you a couple. We're going to wind up with a couple cases that I think are in this spectrum. What is this? So the nuclei are rounding up. There's some that are elongated. The cytoplasm's getting very pink. It's very disordered. So the main question is it definitively CIS? So I'm short. Then you go to the other end. Is it definitively reactive? I'm actually worried about this. This is really disordered, and there's a lot of variation. So this is what some people call dysplasia. Okay? And I can tell you what a lot of people call dysplasia is CIS. Okay? But this is what we're really talking about, these lesions that are short of CIS. I don't know what this is. Could this be flat, like really early low-grade neoplasia? It could be. I don't know. Somebody did CK20. Look at that. What does that mean? I don't know. Okay? So this is a type of case that I would call urothelial atypia of uncertain significance. See, there's no acute inflammation in there either. So that's odd, right? So the question is, do I use the term dysplasia? I do not. And again, the reason is it's not reproducible. I can't show you images and say this is dysplasia, this is not. Like I'm comfortable showing you this is CIS, this is reactive. If I stood up here and told you this is dysplasia, this is not, I feel like I'd be lying to you, and I'm not going to do that. And so if I see thousands of these a year, and I don't think I can do it. That was a great shot. How did you do that?
I have a question. Can we use the criteria of nuclear size in this case? Because this nuclear looks not quite large.
So the question is, can you use nuclear size? So yes, in the sense that it's not enough for CIS. But again, you can't just go by the nuclear size because there's other things in here. This is very jumbled. It's completely disordered. No, it's not, but it's very jumbled, and there's a lot of cell variation, and it's very pink. To me, this is very abnormal. I would be uncomfortable just saying this is classic reactive. It's very unusual. Plus, where's the acute inflammation? Okay, so anyway, this is in my thresholds, this is atypia of uncertain significance. And this isn't going to change my mind. Here's another case. Again, they're very pink. It's bland, so it's not. I think this is not CIS. There's not enough atypia. They're not big enough. There's mitotic figures, and there were a lot of these mitotic figures, and there's no acute inflammation. This is, to me, again, this is weird. I'm worried this is early low grade or dysplasia. Again, someone did the stains, and the kind of, there's a little bit of accentuated staining in the atypical areas, but it's umbrella distribution, and the normal had an umbrella distribution. So again, this is the main point is most urologists, urothelial atypia significance and dysplasia get you to the same thing, which is follow up with continued evaluation of the urothelium. So why didn't I call this CIS? Well, I would argue that they're not, when you look at the areas that so the question is, why didn't I call this CIS? So this is fairly bland. This chromatin's fairly fine. If this is a lymphocyte, maybe 1, 2, 3, 4, they're very monomorphic. Anyway, this is just short of my threshold. I just can't call this. And it's CK20 negative. You can't have it both ways.
You said more times that it's very pink. That's the eosinophilia
Yeah.
pattern.
Yes. It's unusual. Okay. It's just being highly eosinophilic is a little unusual. But so my point is, if you feel like you have to split these, it's the same clinical management. So lumping them doesn't change anything. Okay. Third case, and then we'll break. We'll stop. So again, this is really subtle, but this is a von Brunn's nest, and I think this is just normal. See how this is just subtly different? They're pink. They're a little bit darker. What is that? And again, there was a lot of this. I wanted to show it right up against these. This is very subtle. There's no way in the world I would call this CIS, but it's unusual. It bothers me. And so again, this is another one that I would call urothelial atypia of uncertain significance. And again, this is my comment that I use. I'll let y'all read that. But that's what I put if I call something urothelial atypia of uncertain significance. So that's where we're right at 9 o'clock, so I'm going to stop leaving you with this, and I'm happy to take a couple more questions if you have some more.